Thank you, Carmen, and good evening, everyone. I'm Robin Toohey, Senior Director Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference on the Best of ASH 2018. ASH is the annual meeting of the American Society of Hematology, and it's the world's premier event in hematology where a global community of more than 20,000 hematology professionals from every subspecialty gather to hear highlights from the hottest topics in hematology. This evening, Dr. Brian Durie will discuss key takeaways from this annual conference and explain how this new and important information relates to myeloma patients and caregivers. If you have not yet accessed to tonight's slides, you can do so at myeloma.org. I would like to take the time to thank our sponsors for their support of tonight's call: Celgene, Karyopharm Therapeutics, Sanofi Genzyme, and Takeda Oncology. It's now my pleasure to turn this call over to Dr. Brian Durie.
Well, thank you, Robin. It's also my pleasure to have this opportunity to discuss the best of ASH for 2018. And so if we move right away to what is slide number 2, what I summarize is what was a dramatic ASH this year: 939 myeloma abstracts, so just a huge number of abstracts presented at ASH this year, 2018 now, dealing with myeloma. And those covered both orals and posters, and immunotherapy was a big topic, and I'm going to touch on that as a major highlight as part of my presentation. But there were also many important updates on novel therapies, and a lot of interesting abstracts about the molecular and biology topics. And so, although I won't have time to get into a lot of those, I think it's hopefully reassuring for everyone to know that a lot of work is going on at the basic level in terms of molecular biology and immune biology, which will lead to better therapies for the future. And so, if we can move to slide number 3, the topics for today that I'm covering are 6 topics. One is bispecific T-cell engagers, which I'll explain more in just a moment. CAR T-cells, which are immune T-cells from patients, which are removed, engineered in the lab, and then given back to the patient as a form of immune therapy. A very exciting and new therapy where we have a lot of new information. Frontline therapy, where we have important updates. Maintenance therapy, again, important updates. And then what is an important new topic is how to precisely monitor the status of patients throughout therapy using blood testing, and to reduce, if possible, the reliance on bone marrow and other testing measures. And then what is quite important is what is the role of testing for MRD, minimal residual disease, at the point of relapse. And this becomes important because of very dramatic therapies which have been effective in the relapse setting. And so if we move quickly into the first topic, BiTEs. And so these T-cell engaging monoclonal antibodies are a new type of monoclonal antibody, and so that's important because this is a type of what's called off-the-shelf therapy. So this is something just like daratumumab, Darzalex, which is a monoclonal antibody which can be prescribed and then is available to treat a patient without a waiting period. And so if you look at the diagram on slide number 4, you can see that on the left we have the T cell, and then on the right we have the myeloma cell, and between the two you have the monoclonal antibody, which binds to the T cell and then activates, in this case, 2 B cell antigen sites on the myeloma cell. And this binding process leads to the activation of the T cell, which secretes a variety of things which enhance the killing of the myeloma cell. And so this is a unique and very, very effective approach to attacking the myeloma. And so at ASH this year, we had exciting new information about the use of this type of bispecific monoclonal antibody. And so if we move to slide number 5, this is abstract number 1010, Amgen agent number 420, which was a BiTE in a phase 1 dose escalation study that was presented. And if you look at this scatter plot, you can see that some of the lines go down towards the bottom, and those are the lines which have purple dots and blue stars. And so this is the higher doses of these BiTE antibodies. And so 400 micrograms per day or 800 micrograms per day, at that dose level, you can see that all of the dots and stars go down towards the bottom, and what that means is that there was a dramatic response in the patients. And so at the higher dose levels, patients were responding in an amazingly active way, and so this was tremendously encouraging. But you can also see from the red arrows that I put in there that there was what's a maximum tolerated dose where there were toxicities that occurred, particularly at that 800 microgram per day dose level, which is the maximum dose, which included effects on the blood counts and also some impact with some kidney toxicities. And so it was decided that 400 was probably the best dose for ongoing studies, although a separate trial will probably be using a 600 microgram dose. But very, very strong impact from this 420 BiTE and discovering what would be the best dosing schedule. If we move to the next slide, number 6, you can just see that this induced minimal residual disease negative complete responses in this relapse refractory myeloma patient population. This is mostly coming from Europe. In recent years, a lot of these phase 1-2 type studies have been coming out of Europe before they move into more globally focused trials. But obviously, very encouraging early results. And so if we go to slide number 7, preliminary conclusions, definitely this is encouraging, and it brings into focus how should we compare this dramatic immune therapy with the CAR T-cell therapies. And so that's what I'm going to get into next. If you want to find out more about the BiTEs, we give some resources to help understand BiTEs, and you can click on those later perhaps, and it will tell you a little bit more about how BiTEs work. If we move forward into the CAR T therapies, so how do the BiTEs compare with the CAR T therapies, which we have talked about quite a bit in the past? The CAR T therapies are these engineered T cells, so patients have the T cells removed in the same way that stem cells are harvested, and then these T cells are engineered in the lab and given back to the patient. Now, it turns out that you can do this in a variety of ways, and you can engineer the T cells to attack different antigens on the surface of the myeloma. And what was tremendously impressive, that is summarized on slide number 8, is that at ASH this past year, there were just a whole flood of abstracts on different types of CAR T-cell therapy. The main one that people were interested in was abstract number 955, which was the follow-up of what's called a LEGEND trial, which comes from China, which I will show you in just a moment. But all these other abstracts that I list there were also the subject of great interest, looking at different ways to manufacture the T cells and to use the T cells. One area of interest is to have T cells that maybe would last longer in the patient, so that abstract number 488, for example, BB2121, and then with a red 7 on the end, that's what's called a next generation CAR T cell, where the T cells have a memory function, and they live longer, which could give a stronger ongoing attack against the myeloma, but many different variations. And so we're certainly not at the end of the road in terms of developing CAR T-cell therapies. But let's turn to slide number 9. So what were the results with what was the most interesting abstract, this LEGEND trial from China, abstract number 955, slide number 9. And so this presentation focused on, in this case, 57 patients that have been treated at one of the centers where this Chinese study is being conducted. So if we go to what are called the LEGEND 2 trial details, slide number 10, a key thing about the LEGEND CAR T-cell therapy is that it has a double attack against the myeloma. And on this slide number 10, you'll see that this LEGEND CAR T approach, it has the double attack against the B-cell antigen on the surface of the myeloma, which is felt to make it more active. And so this is proposed as a reason that maybe this LEGEND 2 CAR T-cell approach is maybe a little bit more active than other approaches. What is summarized in the red box at the bottom of slide number 10 is that this is an experience with 57 patients at one of the sites, Xi'an, which is one of the sites, and this is the data as of 25 June 2018, and there's a 12-month follow-up, but some patients have actually been followed out over 2 years at this time point. And so if we go to slide number, 11, I'm sorry, the number doesn't seem to show up on this, but best responses, what is quite remarkable is that out of those 57 patients, 42, which is 74% of them, had a CR or even a stringent CR. And there was an overall response rate, ORR, of 88%. And so to put that in perspective, when you are giving a relapse therapy to a previously treated patient, with a new drug or treatment, we expect maybe 20-30% response rate. And so an overall response rate of 88% is pretty spectacular. And you can see that most of those responses were actually very deep responses, 68% actually MRD negative, minimal residual disease negative. So pretty amazing. And this, if you look to the right, was not much impacted by the dose or the level of the target, the BCMA, on the surface of the myeloma. So fairly dramatic response in a lot of patients. If we go to the next slide, progression-free survival, slide number 12, you can see that if you look at the green curve, that the patients who did achieve MRD negative, and this is important for comparison purposes, if you look at the line at 12 months, 87% of the patients are in remission, so progression-free, still in remission at that 1-year time point. If you look at the red line, you can see obviously the patients that did not have that dramatic response have continued to relapse, unfortunately. But in terms of this therapy and what turns out to be the cost and the logistics of performing this therapy, I would also point out that excellent green line at the top, 87% at 12 months, you'll notice that unfortunately, even in that really good line, there are some patients that continue to relapse, and so that line does continue to drop. So yes, excellent responses, but how long are they really going to last ultimately is a very, very key and open question. If we go to the overall survival, the next slide, slide number 13, you'll see that obviously survival is also good. That green line at the top, very good. 12-month survival, 94%, which is important both in terms of the benefit and the toxicity. So obviously patients are able to get through the therapy 94% survival at 1 year. Now, what people were interested in is how does this compare with the other CAR T therapy, the anti-BCMA, so against the exact same surface myeloma target with a CAR T approach developed in collaboration with the Celgene company, and this is called BB2121, which you may have heard about before. And this is slide number 14, and this was presented at ASCO. So for comparison, you can see here that the patients who did well, their average length of remission was 11.8 months. So actually not quite as impressive as the Legend trial. And so just to put this in perspective. And so if we go to the next slide, slide number 15, what's pretty clear is that we do have a couple of lead candidates in this CAR T-cell category, the BB2121 with follow-up in that trial ongoing, and then this Legend trial just presented at ASH, some pretty dramatic results with this new, very exciting therapy, and also, as I showed you, many alternatives being presented using different kinds of T cells prepared in a variety of different ways. What is their hold? Will there be approvals? Well, I think that everyone is expecting that there will be submissions of probably both of those CAR T approaches, BB2121 and the Legend, to the FDA with a likelihood of approval. But the concern is the logistics of preparing those cells, which take a few weeks, and then the costs of that, and the inpatient care, the total bill could round out to maybe as much as $1 million when you cover the costs of the preparation and then the administration and the hospital costs and everything. And so it's quite a bill to consider in terms of what is the overall benefit of something that is obviously incredibly active, but also incredibly expensive. And so this will be a challenge for everyone moving forward to have a way to introduce this exciting new therapy in the best way. And so if we move forward and try to think about, well, where are we with new myeloma therapies and where does the future lead at the present time, I had the privilege of presenting an update on slide number 16 for the SWOG 777 trial, which is kind of a standard of care frontline therapy, which is a basis for ongoing decision making. And then there was a breaking abstract number 2, which is daratumumab, Revlimid Dex versus Revdex. And so there was tremendous interest in this breaking abstract, plus a follow-up abstract which looked at what is the impact of the presence of the 1114 translocation in the frontline setting. So I'm going to go through briefly each of those 3 abstracts, and there was tremendous interest in all of those at the ASH meeting. So if we go to slide number 17, this is abstract number 1992, the SWOG 777 trial. Key points that people have been interested in: the overall response rate with VRD, a little bit over 90%, and close to 75% having VGPR or better. And so this is a very, very important and helpful perspective for newly diagnosed patients. VRD is active in a majority of patients, and most of those, 75%, could have a very good partial response or better. But it's also not trivial that just with RD, over half the patients will have VGPR or better, and close to 80% will have an overall response rate. But if we go to slide number 18, the next slide, you can see that what is important, that is, if you have that higher level of response and a deeper response, the remission lasts about 1 year longer. And so if you look at the remission duration, the progression-free survival, it's basically 2.5 years versus 3.5 years. So the red one on the top, 41 months versus 29 months, is basically a 1 year benefit from the 3-drug combination versus the 2-drug combination. And so if we go to the next slide, slide number 19, you can see that that translates into an overall survival benefit, also substantially in favor of the VRD. With we have long-term follow-up on this study now, out beyond 7 years, and still 55% of the patients are going strong at 7 years, and so really a remarkably positive outcome with this trial. And the benefit is almost close to 2 years added benefit in terms of overall survival with the triple therapy versus the 2 agents. And then if you go to slide number 20, what's important is that this benefit is seen across all of the different age groups. If you look on the left, the average length of the remission, the median PFS, 48 versus 34 in the younger patients, but even out to age over 75, again, that like a 1 year benefit. So in all of the age groups in the remission, and then if you look to the right, also translating into longer survival, it is amazing. That green curve at the top on the right, that is patients under the age of 65 who received the 3-drug regimen, Velcade, Revlimid, and Dex, and you can see that 60-70% of those patients are going strong out in that 6, 7, 8 year range. So we really do have a solid standard of care with the VRD regimen. However, if we go to slide number 21, people were thinking, well, what about that amazing new drug, daratumumab? What if we give daratumumab, Revlimid, and Dex? So daratumumab, lenalidomide, and Dex, DRD. And so in slide number 21, if you go to that, there was a study presented as the late-breaking abstract number 2, which shows daratumumab, lenalidomide, Dex versus lenalidomide, Dex. So basically identical to the SWOG study, but also focused on the older patients, the ineligible for transplant patients. And this study was called the MAIA trial. A lot of interest in this trial. And so if we go to the next slide, slide number 22, what it shows you is the length of the remission, in this case with the daratumumab, Revlimid, and Dex versus the Rev-Dex. Now for the Rev-Dex, the outcome is basically identical, which is what we just saw in the SWOG trial. And then the DRD is also very, very similar to Velcade, Revlimid, and Dex. The key point which people are paying attention to is that in the MAIA study, the daratumumab will be continued. And so in the SWOG trial, patients went on to Revlimid and Dex as a maintenance because you just can't keep taking Velcade because of the concern about neuropathy. But in the daratumumab trial, patients will be continuing to take daratumumab, Revlimid, and Dex. And so it is anticipated, actually, that daratumumab, Revlimid, and Dex will ultimately lead to maybe a little bit better outcomes versus Velcade, Revlimid, and Dex, in part just because you can't keep taking the Velcade. If we go to slide number 23, you can see that if you compare the daratumumab, the DRD with the Revlimid Dex, that the VGPR is 79 versus 53. The 53% VGPR is the same as in the SWOG trial. The 79% is a little bit higher with the DRD. The equivalent number in the SWOG trial was 75%, so a little bit higher with DRD versus Velcade Rev-Dex. And so for the future, there's a lot of optimism about DRD versus VRD, but we need obviously much longer follow-up. The next slide, slide 24, it just shows you that something that we haven't been paying a lot of attention to can impact the length of the remission, and for the future we need to pay more attention to that. If you look at the translocation 1114 in the frontline setting, you can see here that this actually has a negative impact in patients in the frontline setting. So the blue line here shows you that patients who do have the 1114 actually don't do quite as well as the other patients. So this is something that is actually the opposite of what we mostly think about with regard to 1114, which is a relatively good prognostic factor. So what is the future for frontline therapy? Slide number 25. Well, certainly one can look at 4 drug combinations, daratumumab plus VRD, or Kyprolis, Revlimid, and Dex, or some of the alternatives. Or, as I just showed you, the Dara Rev Dex looks pretty good, and maybe Dara Velcade Dex could look pretty good as well. Would we use perhaps venetoclax to overcome the 1114 problem? What about those CAR T cells or BiTEs? Would these ever be used as consolidation, as part of earlier therapy? Who knows at this point, but these are hot topics for discussion. If we move forward, a couple of interesting points with regard to maintenance. Slide number 26. Ixazomib, which is Ninlaro, the oral proteasome inhibitor. I'll show you data on that. And then, quite important, a study looking at Revlimid alone as an ongoing maintenance versus Revlimid plus dexamethasone. And the interesting thing is that patients seem to do actually pretty well if you drop the dex, which is good news for patients. So if we go first of all to the tourmaline study, MM3, this looks at giving ixazomib, which is Ninlaro, as a maintenance versus nothing. And this is following autologous stem cell transplant, the tourmaline trial, presented by Dr. Demopoulos from Greece. And if we go to slide number 28, what was pretty obvious was that the patients taking the Ninlaro, the ixazomib maintenance, did do better. A 5-month improvement in the length of the remission versus patients not taking the Ninlaro. So this is a very clear added benefit. I think that truthfully people were hoping there might be a little bit more added benefit, but clearly these are difficult studies to do, and I think that it was impressive, even with all of the logistic difficulties in performing this kind of a study, that there was this type of added benefit using ixazomib as maintenance. And so we move to, well, what is the value of dexamethasone in the maintenance setting? Abstract number 305. Very, very interesting study from Italy that was presented actually at our IMWG breakfast. The rationale for this study is outlined on slide number 30. And so you can see that it was focused on elderly, intermediate fit patients, and this is a population over the age of 75 where it's very, very important to know if dexamethasone is needed or not, because dexamethasone has a lot of side effects, what are called comorbidities, especially in elderly patients. So a lot of interest in whether dexamethasone is really needed as ongoing treatment for an elderly patient. And so very encouraging to see in the next slide, slide number 31, the event-free survival. Did patients stay in remission without the dexamethasone? And actually, they stayed in remission. The yellow line and then the blue line, the yellow line is better than the blue line. They actually stayed in remission a little bit longer without the dex, which was interesting. I think in large part because the dexamethasone can lead to some discontinuation of the maintenance. And so This is something that we know about, but we've never had any study data to kind of prove that particular point. And so...
Hi, I was just going to say, without the dexamethasone, and there's also a lot more happiness in the house.
That is correct. A lot less conflict in the household. Yes, this is true. And so, yes, so a lot of interest in this relatively small study, actually, and so strangely, it was a little bit out of left field. People were quite interested in the details of this dexamethasone plus and minus study. And so, looking to the future, if we go to slide number 32, this opens up some options. We have Revlimid, which can be used as maintenance. We have Velcade that can be given subcutaneously. Now we have Ninlaro that can be given by mouth as a maintenance, and then maybe we can look more strongly at cutting off the dexamethasone because patients seem to do just fine without it. And so quite interesting turns in the area of maintenance. So if we go forward to slide number 33, understanding a new biology of myeloma, and this is really quite interesting that myeloma cells, we think of that as being a disease in the bone marrow, but actually what we're learning more and more is the role of circulating myeloma cells. Slide number 33. Myeloma cells do pass out into the bloodstream, and we can measure them, we can detect them, we can measure them, we can study them. And there was a very interesting abstract, slide number 34, abstract number 245, that was presented by the Spanish team, Dr. Bruno Paiva, who's the last author, and a more junior investigator who presented the data, studying what are the features of these myeloma cells that pop out into the bloodstream, and what are they doing there? What are they doing? And so if you go to the next slide, they presented this very helpful model of circulating myeloma cells that can be key drivers to myeloma progression. And basically, as is illustrated here, the myeloma cells can shed off into the bloodstream and can then basically seed and grow in other parts of the bones and lead to new lytic lesions. And so understanding what is going on with these cells turns out to be rather important. And so if we go to the next slide, slide number 36, they studied and found that there were some different genes that were active in these circulating cells related to interferon, the inflammatory response, cell cycle, and the tendency to migrate CD44. And so this turns out to be very important. As you may be aware, daratumumab, for example, is against CD38, and that's very effective treatment. So if migration is linked to CD44, then maybe if we had treatment against CD44, that could really be good to stop the migration and to stop new lesions from forming. And so there was a lot of interest and speculation about these studies and how it might lead into some new and better therapies. It also led to some discussion about how do we monitor in the blood. And slide number 37, I would just draw attention to the fact that there are three new ways to monitor in the blood. One of them is to study those plasma cells I was just mentioning. The other is to use mass spectrometry to study very low levels of the M component, which we've talked about a little bit in the past. And we can also look at DNA, RNA signatures in the blood. And so using blood monitoring, we can find out a lot about the myeloma. Is there myeloma that's active? And what are the details of this active disease? And so there's a lot of enthusiasm and optimism that blood monitoring can be a very key approach and a very helpful and much simpler way to monitor and track myeloma. There were a few slides here and presentations, slide number 38, about long-term survivors. A number of patients from the Mayo Clinic were analyzed. 2,125 followed out over 10 years. Interesting thing that they showed here in slide number 38 is that using a 5-year cutoff, if patients remained in remission for at least 5 years, whether they were on therapy or off therapy, those patients did unusually well out to 10 to 15 years. And so long remissions with a 5-year cutoff. Previously, we've actually used 4 years as a cutoff, but in that 4 to 5 year range, if you're in remission that long, it is pretty promising for a longer-term remission. In our IMWG analysis in slide number 39, we know that ultimately, just with current therapies, over 14% of patients will be in what's called a cure fraction out to 20 years. And if we go to the next slide, we can see that we have been identifying, well, what are the key characteristics of these types of long survivors, patients who would likely be in remission for perhaps 5 years or longer. And this is linked to patients who are younger, who have a normal platelet count, who have actually achieved a complete remission after a stem cell transplant. And these days, patients who have, in fact, gone on to some type of a novel agent-based maintenance therapy. And so these are key things that lead to long survivors and could be a basis for potential cure. In thinking about cure, we're thinking about MRD negativity, and one important concept is whether that could even be achieved in the relapse setting. And it was quite encouraging to see the long-term follow-up of the Castor and Pollock studies, which the names of which you may remember from the past. Slide number 41. If we go first of all to the DRD study, which is the Pollock study. So this is daratumumab, Revlimid, and Dex versus Revlimid and Dex. In this case, in the relapse setting. I just showed you earlier in the frontline setting, but if you look here on slide number 42 in the relapse setting, patients do in fact achieve MRD negative in the relapse setting, and those patients have long remissions and really long survival. And those are the flat parts of these curves at the top. And so a lot of encouragement to think about trying to achieve this MRD undetected or MRD negative, even in the relapse setting, using the daratumumab combination. And so if we go to slide number 43, if you give daratumumab plus Velcade and dexamethasone, which was the Castor study, again, looking at out to 12 months, patients who do have that negativity do extremely well. And so if we go to slide 44, should achievement of this MRD negative, the undetected status, be the goal of therapy in early relapse? And I think there's a lot of sentiment that we should look at relapse differently, that it's not just trying to recoup. It actually is about trying to get a key second or third remission and really have sustained benefit, which could be truly very, very long-lasting. And even the possibility that we could start to cure patients, even although they are moving into that first or second relapse. And so we shouldn't be just looking at that in a newly diagnosed or frontline patient. So before we finish up here and leave time for questions, there were obviously a lot of hot topics at ASH this year. I put 3 things in there, but I'll maybe comment on a couple of other things. Venetoclax, this is the drug which works in patients who have the 1114, who have increased expression of something called BCL2, which is suppressed by the venetoclax. A lot of follow-up data on that, looking very promising. Selinexor, we've talked about this a lot in the past. The key thing about selinexor is that the data have already been submitted to the FDA in the relapse setting with a response rate of 23% in the penta refractory, the really multiply treated patients, and we're hoping that the review at the FDA in the March to April timeframe will lead to an approval of selinexor. So we're certainly hoping for that. Melflufen, this is continuing on slide number 45, a new type of melphalan that I'll touch on in a minute. There is one other agent where there were a few presentations. In addition to daratumumab, there's also isatuximab. This is another monoclonal antibody against the CD38, and there were some follow-up data using this new isatuximab showing that it also has remarkable benefit, just like daratumumab, even although the trials and the data are coming along kind of behind the daratumumab, but also showing substantial benefit. And so we look forward to the possibility of ultimately having approval of the isatuximab as well. And so just a little bit of detail on the new type of melphalan. This is really something quite unexpected. Just to show you in the red boxes at the bottom on slide number 46, overall response rates around 1/3 of the patients, 31% and 33%, but also with some pretty deep responses, including VGPR and CRs, using this little bit new variation on a type of alkylating agent similar to melphalan. And so something just to keep your eye on, some ongoing trials, this Horizon trial, which is mentioned there, showing some promising results presented at ASH. And so with that, I'll go ahead and stop for now, leaving what I hope will be plenty of time for questions. So thank you for watching. Thank you for listening to these details. And again, thank you to our sponsors for this evening's update from ASH, Celgene, Takeda, Karyopharm, and Sanofi. And so with that, I will turn it back over to the operator and leave time for questions that you might have. So thank you for your attention.
Your first question comes from the line of Stephen.
Hi. Excuse my dog barking in the background.
Stephen's got a dog. Stephen's got a dog, yes.
I do. I just joined a BITE clinical trial, and
yes.
I'm wondering, being a very pessimistic person by nature, what factors would contribute to someone not responding as well as somebody else, or not getting as long as a response?
Sure. Well, I think, frankly, we don't know the answer to that question. The trials the patient level trials are just very early. What I showed you was with the Amgen 420. Which trial are you referencing that you might be starting?
It's a Johnson & Johnson
Okay,
trial.
It's a very, very similar one, actually. It's also a CD3 BCMA
That's
trial.
right.
So it's very, very similar to the one that I showed you, which was the 420. So as I showed you with that, at that particular dose level, the responses were pretty dramatic. And I can tell you that the reason that these different trials, I think there are at least three different trials going forward, is that the impact on the lab has been rather dramatic, that there's been dramatic efficacy, and that has been true even at fairly low levels of T cells and also fairly lower levels of the BCMA expression. But right now, we don't know, which patients might be doing better versus others. We don't really have a handle on that yet. I'm sorry. So, but
all right, fair enough.
Beyond the fact that it does look pretty promising.
All right. Thank you very much, Doctor.
Yeah.
Your next question comes from the line of Patrick.
Yeah, doctor, this is Patrick in Dallas. I may have missed something, and you may have been referring to something different than what the slide showed. But on slide 31, you were talking about it being plus or minus dex. But
yes,
when I'm looking at it, it says it's plus or minus lenalidomide. What am I missing?
I'm just looking at the slides now. 31, slide number 31. Well, it may be a little bit confusing, but basically, it's listed there, RDR versus RD. So what that means is the RDR means that both of the groups got Revlimid and Dex. The RDR, which is the yellow, they went ahead and stopped the Dex. Are you with me? So that it's both had the Revlimid and the Dex, but the one group continued with the Rev but stopped the Dex. So I'm sorry if that's confusing.
Yeah, because they just still both of them have a D in them as if they both are still
yeah,
Dex.
there's a lot more detail where this is explained.
Yeah, something
I'm sorry,
behind what I can see.
Shortened it a little bit, but that was the basis of it, where they were looking at what happens if you stop the Dex. Do the patients continue to stay in remission or not? And the kind of surprising answer was that they did even a little better because they were able to continue on, and they ended up not stopping the maintenance, not stopping the Revlimid actually. So that's why there was quite a bit of interest in this rather small study that I don't think too many people were aware of prior to the presentation.
Okay, thank you very much.
Yep.
Your next question comes from the line of Darlene.
Hi. You didn't mention elotuzumab implicity, and I just wondered where that fits in with all of the rest of the...
Elotuzumab?
Mm-hmm.
Yes. So I'm sorry, I did not talk about elotuzumab. I have talked about that in the past, but I did write a blog about it just in the latter part of the year because the elotuzumab, pomalidomide, and Dex is actually quite a promising combination, and there was a study that was released in the fall showing that elotuzumab, pomalidomide, and Dex is much better than just the pomalidomide and Dex alone, and so this is quite promising, and so up to now we've used elotuzumab plus Revlimid and Dex, but I think that in the relapse setting it's much more useful, and it seems like it's much more beneficial to use the Elo Pom Dex, and so I think that this is something that doctors are going to be recommending a little bit more based on the data that came out in the fall. But this was kind of presented ahead of ASH, okay?
Mm-hmm. Yeah, I was on the clinical trial.
You were on the trial, so you know about it. Did you do okay?
Elo Rev Dex, yes, and the trial stopped, but I'm still on that protocol and still in complete remission, so I'm very happy about that.
Okay, excellent. Yeah, so this is good to bring up and for people to be aware of, so thank you.
Thank you very much.
Your next question comes from the line of Michelle.
Hello. I wanted to know, I am day 71 after transplant. I wanted to ask you, it wasn't in the slides, I don't think, what is considered coming out of, I guess, relapse. What is considered a relapse after a very good partial remission after transplant? And would you recommend, I know for the Kyprolis, if it worked before, should it work again after transplant?
Okay, so the first part of the question is that what would represent relapse?
Yes.
And so the simple answer to that is typically where the myeloma protein level has been going up. The strict definition is that if it goes up by 25% or by half a gram or like 0.5, which is 500 milligrams, that technically is what we call biochemical relapse. But many patients where that happens, that they don't actually have active myeloma. There's just like a trend towards relapse. The use of the therapy that may have worked before depends on how long the remission has lasted. In your case, you're describing a kind of a short time frame. So with a short remission, we would tend to not be so enthusiastic about going back to what had been used in the past.
Okay,
Looking for something new or different, especially since we have so many options these days.
Right. Okay. Thank you very much.
Yeah. Okay.
Your next question comes from the line of Alyssa.
Hi. I was wondering if you could tell me the latest recommendations for the length of time to be on Revlimid for maintenance. There's an endpoint after stem cell transplant. I had stem cell transplant 2016, and my hematologist recommended that I be able to stop Revlimid at the 2-year mark, and I've been in remission the whole time. I've also been tolerating the Revlimid pretty well, and I was on a 3-day schedule with no days off, and I've just recently quit taking the Revlimid.
Right. So this is obviously a pretty common and very important question. And so for someone who has taken Revlimid and is doing well at the 2-year mark, my personal recommendation is that you would continue on the Revlimid if you can, if it's being tolerated and, if it's being reimbursed, through your insurance coverage, etc. All the data that we have suggests that ongoing maintenance benefits the length of remission. It's good to stay in remission, and so I have patients, many of whom may be on the line tonight, who have been on Revlimid maintenance for 5 years, out to 10 years, and so if you're tolerating it, I do recommend to stay on it if you can. If you're tolerating it and you can manage to have access to it. I hope that's... Is there
a reason to stay on it every day? It seems like everything
you can adjust the dose and schedule, and that's up to you to discuss carefully with your doctor. But, we start off where I typically use it 3 weeks out of the month. So you take it for 3 weeks and come off it for 1 week. But you can switch to 2 weeks on, 2 weeks off. You can also reduce the dose, 10 milligrams, 5 milligrams, depending on how you're handling it. So I think with these adjustments, it's better to adjust and maybe take it less often or at a lower dose versus stopping it, okay? So maybe talk to your doctor about these kinds of adjustments versus stopping it.
Okay, I will. Thanks.
Okay. All right. Thank you. So we have time for a few more questions, I think, before we have to stop. So maybe 1 or 2 more questions.
Your next question comes from the line of Raymond.
Hello, Dr. Durie.
Hello.
Yeah, I just wanted to ask you a question about some of my relapses. I had a stem cell transplant in 2015. I was on Revlimid maintenance for about 2 years, the middle of July 2017. And at that time, when my numbers started to increase, an oncologist suggested the protocol of Revlimid, Ninlaro, and Dex. That seemed to hold my numbers at a decent level for about 5-6 months, but at the end of a year's time frame, my numbers had gone up from where it had been the previous 12 months. So I'm now on a protocol of daratumumab, Pomalyst, and Dex, and that has been pretty successful. So I was just curious to know that if you have any comments relating to the fact that I think I have the T1114 this situation, whether the fact that the Ninlaro, the protocol that had the Ninlaro in it, wasn't successful, does that bode any kind of I'll say good or bad in terms of future down the road?
Well, I think that the current regimen that you're taking, if I'm understanding, is the Dara Pomdex. Is that right?
That's correct. Yes.
So that is an FDA approved combination. It's a very good combination, and so if that's working, I would certainly stick with it. Now, for the 1114, as I mentioned, we do have this new drug, the venetoclax, which could definitely be considered if you're having problems moving forward. The advantage of the venetoclax is that it is FDA approved and commercially available for lymphoma, leukemia, and so your doctor can have access to this, even although it's not specifically approved yet for myeloma. But I would stick. It's always good to stick with something that's working, but then this venetoclax could be something in your back pocket for the future.
Okay. So in other words, what I think you're saying is probably since the Ninlaro did not work at a first remission,
right.
First relapse, probably would not be something that choose for.
Exactly. Yeah, I think not. Yeah, I would not revert back to that. Yeah, in this case.
Good.
Yeah.
Thank you very much.
No worries. Mm-hmm.
So, Dr. Durie, we actually have an email question here. If we'll wrap this up with the email question from Jack. He wants to know.
That is fine with me. Yeah. So I think that we're close to the witching hour here, and we've covered a few questions. So we can have a plan to answer by email and by follow up.
Okay. So please don't forget that the replay of this teleconference will be available early next week, and you can access this and all previous IMF teleconferences at myeloma.org and simply click on IMF TV. Last but not least, if you have questions, the IMF info line has answers. 1-800-452-CURE, which is 2873. Missy, Judy, and Paul are happy to take your calls, and they are available Monday through Friday from 9 a.m. to 4 p.m. Pacific. Once again, thank you, Dr. Durie, and a special thank you to our sponsors that continue to make these valuable calls possible: Celgene, Karyopharm Therapeutics, Sanofi Genzyme, and Takeda Oncology. And most importantly, thanks to all of our patients and caregivers tonight. We hope you found this helpful to continue your important conversations with your own healthcare team. Have a wonderful evening, everyone.